Gary Gottlieb, who is a renowned figure in the field of global healthcare and social justice, well known for his pivotal role in Partners in Health. As a prominent physician and healthcare leader, he has dedicated his career to addressing healthcare disparities and providing high-quality medical care to some of the world's most vulnerable populations. With his extensive experience and unwavering commitment to humanitarian causes, Gary has played a vital role in shaping PIH into a leading organization in the global health equity movement.
Well, good afternoon and welcome. It's wonderful that you guys have chosen to take Thomas and James's course and also allow us to participate in your experience academically. Frankly, we depend on you to reshape the world and to essentially understand the importance of the equity that is necessary for healthcare to be delivered in a way that is responsible and thoughtful, not to one, but to all. The premise of my part of this presentation, which I think is more modestly informed than either Jamie's in terms of a variety of issues around the overall biopharmaceutical industry and its focus on creating access to care, and Dan's personal experience working in Kenya, is really from the perspective of an American NGO as that I was on the board of for 10 years and led called Partners in Health, that you probably have some familiarity, that was founded by Paul Farmer, Jim Kim, and Ophelia Dahl, who were close and dear friends of mine, well, so in timely death. It's a short time ago. And I think the overall thesis here is that pharmaceuticals are a critical component of creating social justice and equity in the delivery of healthcare. Access to truly being able to bring 21st century care to those who need it depends on the availability of both devices, supplies, as well as treatments. And at the same time, they are they're only modestly effective unless we build sustainable healthcare solutions. And having strengthened healthcare systems is the critical component. Having workforces that are knowledgeable, supply chains that work, systems of delivery that are exceptional. And so putting those pieces together, I think, is the premise of my part of this presentation. These data that you see in front of you, can everybody see my screen? Thomas, can you just raise your hand and tell me you can see my screen? Is that okay? Okay. Clearly, one needs to spend adequate funds in order to have health systems that are strong enough to deliver the appropriate care. The overall mission of Partners in Health, which I think is quite similar to the view of anyone who embraces social justice as a critical component of healthcare equity, is the notion of that every piece of equity ensures that every person has the same care that's available to you or me in the developed world, and that we ensure that that equity is just not defined by very, very modest resources or being able to settle, but that a preferential option for the poor is critical. That today, I'm sorry? That the most advanced cancer treatment should be available in Boston. It should be available in Port-au-Prince, Haiti. It should be available in Lesotho or Malawi. These are some of the countries that Partners in Health works in, and you can see that the per capita healthcare expenditures on the overall healthcare system in the public and private sectors is less than 1% of what it is in the United States. One can argue that healthcare expenditures are too high here, and you know that our outcomes relative to other developed countries are in fact poor because we have an illness care system rather than healthcare system, and our lack of investment in public health creates outcomes that are considerably more modest, and our lack of a social safety net creates severe inequities in terms of access to the social determinants of health, which really are probably the most important determinants of how well people do in terms of overall life expectancy. And public health outcomes. But you can see that overall per capita expenditures in these countries is less than 1% of what it is in the United States, and the outcomes are more than 50-fold worse in key critical areas that are often associated with global healthcare delivery, and that's the overall prevalence and treatment of infectious diseases, particularly infectious diseases that we've figured out ways of managing with pharmaceuticals, and in fact preventing or eradicating in the developed world, and key other critical elements like maternal mortality and child mortality. The challenge here is that the funding of our healthcare system in the United States and in much of the developed world comes from tax dollars, comes from the productivity, the gross domestic product of that country, as well as overall investments in the public good as well as the private sector. The challenge in the developing world is that there are so many different funders who have a variety of different agendas that are so poorly coordinated that they don't really create markets, they don't create reliable public health components or reliable infrastructure. And the agenda of multilaterals, bilaterals, and the private sector are of those agendas, while all having missions that are positive and bring great good, bring it often in a fragmented way, in a way that's not coordinated, in a way that can't be predicted by the ministries of health or the overall sector locally and federally within those countries, and doesn't do anything to inspire the kind of markets that Jamie and Thomas will describe as potentially creating solutions to some of the problems around access to pharmaceuticals, to devices and other components that are essential, and also don't create a reliable set of funding to have enough health system strengthening that reduce the likelihood of essentially medical deserts where there's no human capital that is adequately skilled to provide that care, or the systems and stuff as well as capital that are necessary. You can see a few of the very important, well-known multilaterals really overseen or related to the World Health Organization, financing mechanisms, funding mechanisms that bring together different countries, resources, as well as a set of targeted entities that focus on specific areas like Gavi and CEPI that focus on vaccines and treatments, COVAX and the COVDP, which were focused specifically on immunization and treatment associated with COVID-19, and UNAIDS, which is focused on HIV and other related areas and aid. Similarly, the bilaterals, which are known to you as well, USAID being the largest of them, really comes out of the United States State Department. And while its intent theoretically is to do great good, the places in which it invests are politically driven. They're driven by our relationships with specific countries, strategies that we have around trying to create relationships with them. Some are more broadly focused, like the CDC, which is focused on prevention of various kinds of catastrophic public health outcomes, and or promoting health in a positive way overall, and then a variety of other country-related bilaterals. One truly important bilateral, which you see being politicized tremendously here in the United States, is PEPFAR, which President Bush made a massive commitment to bringing 21st century treatment to the global south for HIV, and it's one of the areas which is being debated right now by Congress to not renew, almost shockingly, because of a variety of political and extremely conservative leadership who somehow see that this is providing aid in a way that is disconnected to their agenda. But all of these components become agenda related and politicized, and they're fragmented. So you see here funding that may focus on a specific vertical like HIV care or TB care or COVID-19, but not more broadly based on the horizontal nature of building a foundation of strong health systems. Even private foundations only target selected countries, selected areas, or selected specific activities. I mean, the funds that come from the Bill and Melinda Gates Foundation are certainly the size of aid of almost any single country outside of potentially the United States and different others. And the Gates Foundation has very, very siloed, specific, and narrow verticals that it focuses on, or specific industry-related solutions. And while it speaks to the notion of health system strengthening, it does not have a true agenda that invests in that way around the human capital of bricks and mortar that's necessary to deliver the broad base of a public health system. And the NGOs often are responding. MSF, probably the largest of these NGOs, Médecins Sans Frontières, which is in the United States identified as Doctors Without Borders, focuses almost entirely on emergency response and entirely relief, and doesn't work generally in partnerships with ministries of health. It kind of operates where it wants to, when it wants to, and then gets agreements from ministries of health, which means that its agenda is quite different. And when it's done with its activity, it often leaves and doesn't leave infrastructure or human capital behind. But these are all entities that do great and tremendous good. But you can see the fragmentation is remarkable. And if you're looking at your budget as the prime minister or president of a country, or a ministry of health, or a finance minister, you're looking at a set of grants or of agreements or a set of activities that are accounting for a massive component of your healthcare spend, and rarely is the country defining its own agenda in a way that drives a long and preservable, sustainable set of results in that regard. That makes anything that happens with new discovery difficult and expensive. So in countries that have substantial prevalence of hepatitis C, their ability to gain access to cures that have been identified over this period of time with those modest sums will depend entirely on multilaterals, bilaterals, or foundation funds, or perhaps the largesse of a pharmaceutical company, unless there are markets that make it feasible to be able to obtain those medicines in a sustainable way more broadly and overall. So I don't pin all of the solutions on challenges that we have with protecting IP in the pharmaceutical companies. I think we have global policy problems that aren't focused on creating, to some extent, a high degree of equity in health system strength, particularly at the public sector side, because most of the poorest people living in lower and middle income countries do not have the funds available to themselves, or may not be in places that have universal health coverage, and therefore can't access systems that aren't truly public. Pandemics are extraordinary black swan events. They're events that change the environment, and the environment that they change in healthcare is obviously preeminent in our thinking about policy and how to relate to them. And I think it is important to understand the structure of health systems and the effects potentially around pandemics. We haven't really studied well the true long-term effects of COVID, and frankly, the high prevalence of COVID. Thomas introduced just a few minutes ago. He said, we'll see how many students are available. We have an outbreak of COVID on the campus at Yale. That's in a place that has endless access to resources, a place that is the center of privilege for its students and for its community overall. And we're seeing a substantial outbreak that is causing more infection, more peril, probably more long COVID in unsuspecting people, and will cost perhaps not within that community lives, but if the exposure of vulnerable populations, impoverished populations, even here in New Haven, would essentially cause that peril. Think about that within structures and environments where those resources don't exist. And we have studied and looked at the effects of the Ebola epidemic, which was just a few years before the COVID epidemic. And let me just show you kind of a few of the effects overall. Just remember, Ebola was endemic in and around Africa for an extended period of time. We saw evidence of the virus in various places and small outbreaks, but the pandemic that we saw in West Africa was really a reflection of a confluence of very, very weak health systems that had been battered by poverty, by persistent instability in government, and by, frankly, ongoing revolution in those governments in places where there wasn't much stability, and in places because of the violence that existed between militarized government and other resources. The trust of government on the part of people was very, very low, and there were a substantial number of people who had left places where there was substantial infrastructure to kind of to resettle in deeply rural areas for safety and for protection overall from what they felt were imperiled components of society. In West Africa, Paul Farmer used to talk about the notion of health system strengthening, reflecting staff. Excuse me, just reflecting overall. Sorry, 1 second. I apologize. I'm going the wrong direction here. So reflecting the fact that there is not adequate staff, space, and systems, which is what is necessary to deliver public health and to deliver acute care healthcare. When we went into both Liberia and Sierra Leone, we essentially saw many hospitals, and the hospitals that we started to work at in the districts that we agreed to work on with the government, and set up the first public sector treatment of Ebola, that there were basic hospitals that had no electricity, basic services like running water, and no access to oxygen, and obviously the human capital was depleted as well. Increasingly with Ebola, people were afraid to go to work, so there was no staff in those places, essentially patients or people from the neighborhoods were only coming really to die in that environment. We look back to it, we're part of a 2008 assessment of surgical and other related services in Sierra Leone to see essentially what kind of infrastructure would be necessary. This was long before Ebola, to be able to build adequate resilience and adequate services to the populations around them. And an easy comparison of public sector hospitals in Sierra Leone at that time, we found that they compared unfavorably to U.S. Civil War field hospitals in a variety of different dimensions. Just think about that. Think about the notion of providing rudimentary services to people in the context of severe trauma that was set up in the midst of really one of the great disruptions to American society in a horribly violent period. The public sector hospitals in a place that was highly populated in the 21st century rarely were able to perform those same overall functions. So that gives you a sense of, despite investment, that how weak those health systems were overall. An epidemic or a pandemic then causes the dissolution of that infrastructure. As I said, people don't show up to work. People, the ability to do stuff that had progress associated with it, even if it was more rudimentary, like vaccination programs, maternal health programs, nutrition programs, programs that were focused on treating infectious disease like HIV and tuberculosis, basically dissolved almost instantaneously. You can see overall in Liberia what happened to basic measles vaccination rates amongst children, which came from Gavi and CEPI and the other structures that were part of the multilateral programs that I described before, or what happened to family planning, which is kind of the core of all kinds of preventive services for women and children, for women, their babies and children, because it brings women's health care kind of at a base. And both of those dissolved within months of the beginning of the Ebola pandemic, and the outcomes a year later, after the first incident cases in November, to a year later in November of 2014, in key areas that had been improved for long periods of time, got much, much worse. So the death rates associated with the pandemic were far more than the Ebola-related deaths. There were deaths that were related to maternal mortality, the most important technology in improving maternal mortality is for deliveries to come out of people's homes and to be in institutional settings where they can get appropriate care and where one can do prevention of the catastrophic outcomes of childbirth, like eclampsia and bleeding and other components, severe hypertension and seizures associated with eclampsia. And you can see that all of those essentially dissipated extremely rapidly because the systems were not strong enough to be resilient and to protect them. And years of improvements essentially dissipated almost instantaneously within a year of the time of the pandemic. And so health system strengthening is critical to have a core of activities, both to deliver the care that might be necessary by a catastrophic event like a pandemic, but also to sustain all of the other components of critical public health care, prevention, as well as acute care. To some extent, to think about how do you build that, it isn't so badly expensive. It isn't so crazy to do. It's about building from the bottom up and then building, to some extent, enough human capital to take on other elements that would be necessary to do more prevention, to do incremental treatment, and then to be able to use pharma when it's in fact available, or to make certain that it's available so it has useful life in the hands of expert populations. An example is the work that we did in Rwanda. Partners in Health was invited into Rwanda in 2006 by President Kagame as part of 20-year set of investments in improving the economy, and the notion that healthcare was a critical piece of it. In the early 2000s, life expectancy in Rwanda, unrelated to the genocide because of what the genocide had done to the overall public healthcare system, was 39 and a half. And we were invited through a relationship with CHI, the Clinton Health Action Initiative, to go into the three poorest districts that had virtually rubble for their overall public healthcare systems that were deeply rural Rwanda. And Rwanda, there's a high population density in rural areas. So each of these districts had about 400,000 people, and we were taking care of about 1.2 million people. We put together a paradigm based upon community health workers that were in the field, making home visits, basically people assigned to their own neighbors in their own neighborhood, doing a set of screenings and interventions, who were then supported by public health nurses and healthcare outposts, and then supported by health centers, then supported by district hospitals that we helped to rebuild in our districts, and then they were supported by referral hospitals. So the pyramid overall takes advantage of the availability of human capital, a high degree of training, and then a supervisory paradigm that starts from the base closest to people's homes. Remember, if you're going to deliver medicines, if you're going to deliver vaccines, if you're going to make certain that people are adherent to those medicines, which are complex to use, if you're going to have supply chains, they have to be as close to people's homes as possible. So a brilliant discovery that requires cold chain for a Pfizer vaccine is going to do nothing unless there's access to that cold chain, and then there are people to be able to deliver that, people who are trusted, people who are within people's communities to be able to monitor the side effects. It's not like just walking into a CVS. There isn't one in the neighborhood to be able to do that. And it's not like there's an ICU near you if that's available. So we did this same, we created this pyramid with about 10,000 community health workers and taking care of about 1.2 million people. The government overall then used that paradigm and nationalized it to the pyramid that you see here. But even in 2011, as you can look at the bottom of this slide, there was a relative medical desert, but the outcomes that were associated with this kind of intervention were dramatic in reducing HIV infections, in reducing tuberculosis, in reducing maternal mortality, in reducing mortality of under one populations. And while the rates overall were considerably worse than the industrialized world, the life expectancy effects were dramatic. So life expectancy this past year in Rwanda exceeds 70 and is dramatic. And it was the country that met all of the Sustainable Development Goals prior to any others in these areas. Speak to some of the issues around the government and its effect on people, on all aspects of human rights. But in this case, the overall healthcare paradigm, which we've also used in Malawi and Sierra Leone now, in Liberia now, in Lesotho, it have had dramatic effects on these kinds of outcomes, and they're sustainable over periods of time. But at the end of the day, the preferential option of the poor is dependent on tomorrow's discovery, on making sure that cancer services are the same in rural Rwanda or in rural Haiti as they are in Boston or in New Haven, proximal to the Yale Medical Center. Otherwise, these discoveries are for naught. It's not just about giving these people rudimentary treatments because they happen to be born in the wrong zip code or because their countries are more impoverished. All discovery, essentially, if it's appropriate and has the kind of cost effectiveness that's necessary to improve the human condition overall and sustainable, needs to be available to all. And basically, we Partners in Health became involved with multi-drug resistant tuberculosis because in its venues, it basically saw people getting sicker and sicker. And when we would start to treatment for something that had been eradicated in most of the industrialized world, but was still highly prevalent. I mean, there's still, a 1.5 million deaths a year associated with tuberculosis today. If people are not on a protocol for months and months, if they disrupt that protocol and then start again, tuberculosis, essentially the mycoplasma mutates so well that it rapidly becomes resistant, and it becomes resistant to multiple drugs. And even babies born with tuberculosis that essentially or who get tuberculosis rapidly after birth because they're exposed to family members will have multi-drug resistant tuberculosis. It's not like somebody who's had it for a period of time. It's what the bug is that people are exposed to. And it requires people to be on multiple drugs for a long time, drugs that make people sick, drugs that are hard to take. And if the cost burden is too high, obviously drugs that are hard to administer. And you can see here that the price variation around drugs that were available for treating multi-drug resistant tuberculosis in 1997, and there's still a high degree of that variability, but I'll describe to you a kind of a process in which we tried to affect this that's still in place, was very, very high. And the group at PIH had started to show that doing observed treatment for tuberculosis plus a set of social as well as other medical interventions could improve outcomes dramatically and reduce the effects in impoverished populations. They showed this in Haiti and in Peru, and in the Russian prisons post the breakup of the Soviet Union. And they put together a conference to try to figure out how one could access drugs in that regard and deal with that price variation that was overall. Created a proposal to the World Health Organization to make those second-line drugs essentially a model list of as part of the WHO's essential drugs. But the question is, how could they be accessed, and how would they be accessed easily? A report that they put together ultimately created something called the Green Light Committee of the World Health Organization, which is still in place and still works on creating access to MDR-TB drugs and bringing new drugs and also new treatment paradigms to people with multi-drug resistant tuberculosis, which, as I said, is still killing more people than most other infectious diseases at the present time. And this model is one that started to create a market for these medicines that had an effect on price that speaks to some of the issues that Thomas can speak to so thoughtfully. Basically using a model that had been used to be able to disseminate a vaccine for meningitis. Basically, the WHO became the purchaser to essentially procure a majority of the supply. In fact, creating a market that also would assure the quality and would grant access to those who were delivering the drug based upon their quality guidelines and having adequate health system strength to be able to deliver those medicines and to essentially get rid of irrational use, which could cause more treatment resistance and make the drugs useless, and do a set of technical monitoring, and then created a partnership among a variety of entities, not-for-profit and public, to be able to support this over time. Médecins Sans Frontières, which had a fabulous drug procuring process for its sites, basically procured all of them on behalf of the Green Light Committee. They made a deal first with Lilly, who was one of the manufacturers, and then got others to be able to follow, particularly generic manufacturers. And the results were substantial declines in overall drug prices. And I raise this because this is an approach that informs some of the notion of market effects and market partnerships to be able to essentially create sustainable reductions in prices. We've talked before about the issues of insulin access. The United States has tried to create, as you saw in the Inflation Reduction Act, there was a major effect theoretically on insulin-related prices that for the Medicare population, but that clearly has not created sustained changes in the marketplace. The challenge for diabetes is not dissimilar. For chronic disease as opposed to an infectious disease, you have to do screening. You have to be able to have strong enough health systems to be able to deliver drug, to be able to monitor people. There have to be supply chain issues, not just in terms of drug and access, but observed treatment to make sure people are getting their medicines every day, but also that they have adequate supply to do glucose monitoring and to have strips and a variety of other critical elements, including syringes, needles, to also then be able to monitor which medicines people need, whether orals. We were not putting people, I'm not suggesting putting people on Ozempic at this point, despite my wanting a preferential option for the poor, intermediate and rapid insulin. And just was focused specifically on type 1 diabetes, which is essentially for populations who have essentially diabetes needs that are significantly likely to be insulin dependent over a lifetime as a result of a lack of overall pancreatic function, and where the incidence rate in childhood is extremely high and mortality rates are exceptional. And basically the overall 6-month mortality rate, the average life expectancy of someone who diagnosed with diabetes in sub-Saharan Africa without access to insulin is 1 year or less. It's less than 6 months from an index case of ketoacidosis, which is kind of the shock response to not having insulin for a baby or for an infant. But the notion of being able to get that medicine in the hands of someone who is in a remote environment without adequate health system strength is quite poor. You can see that insulin can be manufactured for as low as $2.28 a vial, and the price differences you can see vary remarkably. If you kind of map that onto what the overall accessibility is for those who are paying out of pocket, it's up to almost a week's worth of wages in Burundi overall, and globally, about 50% of people who need insulin to survive are without any regular access. For PIH, the overall price per vial that we were paying a couple of years ago was just under $10. So the variation is terrific, but having to work up this pyramid is pretty critical in order to be able to essentially have somebody not just survive, but thrive and have a normal life with diabetes, which is completely feasible in most of the rest of the world. The notion of controlling those prices, having markets for them, or the notion that a drug is generic means that it's accessible and cheap, is really defied by some of the pricing issues that we've seen around generic drugs. You heard about the Mylan issues with EpiPen as a major headline here in the United States. We know that we have a good friend named Martin Shkreli who's been spending a long time in prison because of the manipulation and profiteering of prices associated with generic drugs, and generic drugs that have been off patent for years and years defy the rationale that one has to invest, essentially create returns associated with patent protection and with all the R&D that's associated with drug development, which isn't the case for purely generic pharmaceutical companies who bought licenses or have started to manufacture those drugs when they're off patents. And a perfect example is the second bullet you see here, hydralazine, which is basically, it's an antihypertensive that was old when I was in medical school. So just, take a look at me and then try to match that to the age of a drug and its overall patent protection. We saw a 50% increase in the price of hydralazine in 2019 at Partners in Health. Ciprofloxacin, which is an antibiotic, Cipro, that's commonly available and used, 33% increases. And tamoxifen, which is the cheapest, easiest oral breast cancer drug that's available for both treatment and for prevention. We saw a 100% increase in price. Those are all off patents for for a generation or more. The issue of all these issues were certainly not solved for COVID, and you know the story of essentially vaccine inequity. What's interesting about vaccine policy is that there seemed to be an ignorance among the countries that were subsidizing or were helping to pay for its development overall, in the notion that viruses might mutate and get on a plane and then kill people back at home, even if you had access to vaccines, if you didn't vaccinate people all over the world, and that the notion of vaccinating as many of the 8 billion of us that one could as rapidly as possible was in the interest of every human being on the face of the earth. So that investment in vaccine discovery for me was investment in vaccine discovery for somebody in Haiti or in South Africa or in Ethiopia or in Zimbabwe. And you can see that in the first 2 years of COVID, the difference and the disparities in access to vaccines was dramatic and remarkable, and absolutely contributed to many of the strains and mutations that existed, but obviously contributed to unnecessary death, destruction, and the destruction of economies that even those that were just starting to thrive in the developing world, and probably instability of some of their governments. There was a massive multilateral approach that the WHO had to try to create vaccine equity as rapidly as possible, almost shortly after, at roughly the same time as most of the vaccine efforts that were going on in the developing world, and largely the efforts that were going on at J&J, Moderna, and Pfizer were finding markets for their goods and or subsidies for them. Created a consortium of donor countries, which were largely the United States and the European Union, a couple of donor countries that were also self-financing participants and donors like Australia and Saudi Arabia, and then countries that essentially were recipients of the potential of those vaccines. And you can see here that even over that 2-year period of time, this was as of really 2 years into the heat of the pandemic, the coverage of the population still was just tremendously different, and the inequities were pretty remarkable. On the left-hand side of this slide is coverage over 10% of the population, with WHO total member states being in the first column, and high-income countries being in the second, and low-income countries being in the far right. And you can see the coverage over 70% of the population, even 2 years into this, were and a year and change after the first vaccines were discovered. The vaccines were first licensed in December of 2020. You may remember the announcement during the presidential, right after the presidential election, of the first vaccine being approved. And so you're about a year and change after that, year and a quarter, and still over 70% of the population didn't touch a single one of the lower income countries overall. This is a map of the doses per 100 people, and remember, almost all of the vaccines and the most effective vaccines were all 2-dose vaccines. This doesn't include data for China and Russia, who kept their data relatively secret about their own developed vaccines overall. So there's still a substantial portion of the populations that had some access to some vaccine, perhaps not at the same level of efficacy overall. There were 34 countries that a special part of the COVAX project tried to both create through UNICEF and other elements, some health system strengthening components, as well as vaccine access, to be able to try to increase those pieces. And you can see overall, they still continue to be relatively slow in their uptake, with some countries doing a little bit better than others, but others, particularly those with very, very poor health systems, were unable to really absorb that. And this slide kind of shows vaccine coverage versus pandemic health system strength overall. You can see the countries that had really poor health systems overall were really unable to to use the effect of probably the greatest rapid discovery of our time, a vaccine that was developed within such a short period of time. So I think the story here is an important one. The story is, if we use solutions and create consortia and focus in a deep way, we can create improvement in pricing and make some of the great discoveries we have as rapidly as available as possible. But it takes affecting markets. At the same time, without true investment in health system strengthening, our ability to deliver, to eradicate, to improve, and to essentially improve the human condition will be significantly limited. Thanks, Thomas.
Wow.
Have to be unmuted. So any questions from students? Questions, comments?
I did have a quick question. Firstly, thank you for your presentation and for all of the data that you shared with us. I was curious as to how the PIH paradigm model was received by the community in Rwanda. I know that sometimes there are maybe some cultural barriers that play into initiatives that are aimed to support or help countries that do need support. So I was wondering how, in your experience, that was received with the PIH paradigm in Rwanda specifically.
So I would go beyond Rwanda, because PIH is in 7 different countries taking care of about 10 million people, and the cultures are all different, and the governments are different, and the ability to deliver on these things is different. PIH, started in Haiti, and basically was starting as a small not-for-profit in a partnership with a kind of a church almost, and in a very rural area of Haiti that had been deeply affected by essentially a movement of a dam that wiped out a set of neighborhoods and caused, or a set of villages, and caused immense poverty and a lack of access to care. And it was only after it had been around that it then created a partnership with the government, and then created as its overall strategy only partnerships with the government, because the government was really the only consistent resource that we felt that could represent the community in a consistent way. That also comes with the fact that how good or bad the government is, how much it's willing to expend, how corrupt it is, or how the government is seen by the population affects how PIH's resources will be uptaken. The real advantage I think that PIH has had is a sense of humility and accompaniment, where it will never impose without essentially a reflection of a tremendous approval by not just the federal government, but by local ministries and then by local peoples. And so, which is very difficult. It requires, obviously it's going to be different in Lesotho than it's going to be in Malawi, and certainly different in Haiti than in Rwanda. Haiti having almost no government at the present time, and Rwanda having a strong person in government, and the degree to which people trust government is different in all of those places. PIH usually comes on board and will, everything it builds, it gives to the country. So if it builds a hospital, if it builds laboratories, they basically are immediately the property of the government. All of the employees of PIH are people of the countries in which it works, and then how they're employed depends upon what the government will allow, whether it wants those people to be topped up in their salaries, because and in many of these countries, frankly, the employees of the government aren't paid for months over a period of time. So a hospital in Sierra Leone, for example, nurses weren't paid for months and months at a time. So some subset of nurses would charge the patients at the bedside and charge family members at the bedside for access to water, access to food, access to medicine. Not because they're bad people, because their own families were starving to death. So we would come up with a relationship with that hospital, with its leadership. We would leave that leadership in place. We would work side by side and accompany them, and then top up the salaries of those people and prepay them salaries so that they would make sure that they were stable and they could come to work. And then the incentives would change for them in terms of their work. It just depends on, it's just so dependent on individual places and areas. So in Liberia, when we went there. We were in the poorest county. 87% of the population lives in abject poverty, less than the equivalent of $3 a day in Maryland County. And if you just see the place, it's this gorgeous place that's on the coast that basically you can follow the trail of burned out homes where people were essentially fled from during periods of government unrest. And while they liked the new government, theoretically, they didn't know who to trust, and nobody would come to the hospital because the only reason you go to the hospital is to die. So nobody would ever trust the hospital because all they'd see their family members who were being separated from the hospital, and then they would die and not come home. So the first thing we built at the hospital was a set of pediatric resources that had nutrition, medicines, and several pediatricians. There were like 2 in the entire country. We had several who were expats from the United States and Europe who were incredible. And all of a sudden, people's babies started to live and their children started to live. So then the adults wanted to start to come to care, and the line outside the hospital was like around the block. We had a health center there that was doing deliveries, and it was doing deliveries. There was no roof, and water would come in on a rusty table, and women would die in childbirth. There was a health center right near it that had never been completed, that was part of some project. We completed the health center, basically did deliveries, did care, did a variety of maternal health claims. The line was like out on the road to be able to come to the health center. When people know what's good, we found we start to run nutritional clinics in Haiti, and they would stock out. They had no therapeutic food for babies. People would come with their babies, and everyone would be nice to them. They'd have nothing to give them. So we would make sure that the supply chain was effective at every single place, so we had stuff all the time, so that the doctors felt that they could really work as doctors, so the nurses could really be nurses, and it changed the paradigm as to how you provide care. It's all, accurate empathy is all about providing what people need, and listening as much as possible. And it's really hard. And community health workers are the key because they know their whole neighborhood. So if you assign one in Rwanda, we would assign one community health worker in her neighborhood. We would train her, and she would train us, and she would be assigned 64 families. So she would know when every girl got her first period to start to do family planning. She knew every girl would miss her first period to start to get maternal care, and to make sure that she was HIV tested, and to make sure that she was on medicines if in fact she was HIV positive, so she wouldn't transmit HIV to the baby, and then that we would be able to make sure that that if she lived in some remote place, that we would she would go to a maternal waiting home, so she wouldn't have to walk 15 hours to get to a place where she could do a delivery. And so she would anticipate that. And if she had some complication, we would get her to a hospital so that she could have hospital service if that was necessary. So it's all building up, from the bottom up, and being taught by the community what they need. And that's not different for anybody. In each of those zip codes, every person wants their child to be beautiful and to grow and to live and to thrive. Every person wants their parent to live as long as possible. I think the care in most of these places is worse for men because all those vertical programs basically eliminate, don't have real public health horizontals. So nobody's checking people's blood pressure. So you're sitting with men, seeing, young men with strokes and with hypertensive cardiovascular disease, because at least women are getting some care around maternal care, and children are getting some pediatric care, but that infrastructure of particularly in non-communicable diseases really has to include everybody. So old people and men end up getting neglected, and you need to be able to build those programs around them if there are any old people in those places.